Hello and welcome to the topic Dysthymic disorder in the psychiatry module. By the end of this topic, you should be able to define dysthymic disorder, discuss the pathophysiology and causes of dysthymic disorder, describe the clinical manifestations of dysthymic disorder, discuss the management approach to dysthymic disorder, and finally, discuss the complications of dysthymic disorder. Let's get started. Dysthymia, also known as persistent depressive disorder, is a mental and behavioral disorder, specifically a disorder primarily of mood, consisting of same cognitive and physical problems as depression, but with longer lasting symptoms. Persistent depressive disorder is a depressive mood disorder characterized by a chronic cause and an early and insidious onset, which it could occur before the age of 21 or in childhood, when it's associated with higher risk for comorbid personality disorders and substance use disorders. Dysthymia can be divided into two subtypes, the anxious dysthymia type and energic dysthymia. The described subset of patients with anxious dysthymia as having pronounced symptoms of low self-esteem, undirected restlessness, interpersonal rejection, help-seeking, and to make lower lethality suicide attempts, as well as to have a better response to selective serotonin reuptake inhibitors. This group is compared with patients who have energic dysthymia, characterized by low energy, hypersomnia, and anhedonia. Patients with energic dysthymia, the authors suggest that they may have a better response to treatment with agents that increase noradrenaline or dopamine. The involvement of serotonin and noradrenaline systems in dysthymia is suggested by the disease's positive clinical responses to serotonergic and noradrenergic medications such as SSRIs, serotonin or noradrenaline reuptake inhibitors, SNRIs, and tricyclic antidepressants. Abnormalities in neuroendocrine systems, especially thyroid and hypothalamo-pituitary adrenocortical systems, have been linked to depressive disorders in general, although the HPA axis has not been adequately studied in dysthymic disorders. The causes of dysthymia, although not clear, is likely multifactorial. A biopsychosocial formulation considering the interplay of family history and other genetic factors, medical problems, psychological makeup, and coping strategies and social stresses is helpful when considering the causes of dysthymia. The most common symptoms include a negative, pessimistic or gloomy outlook, depressed mood, restlessness, anxiety, neurovegetative symptoms, and loss of pleasurable activities. The DSM-5 criteria for persistent depressive disorder highlights that depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others for at least 2 years. In children and adolescents, mood may be irritable and duration must be at least for 1 year. Presence while depressed or 2 of more of the following symptoms, which include poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration and or difficulty making decisions, and feelings of hopelessness. During the 2-year period of disturbance, the individual has never been without symptoms as mentioned above. When it comes to assessment, you can begin with, of course, history taking, followed by physical exam findings. Although no physical findings are pathognomonic for dysthymia, an examination may reveal evidence of weight gain or loss, low body temperature, brittle nails and hair, slow reflexes, and other symptoms suggestive of thyroid dysfunction. A mental state examination for a person with dysthymia might include the patient being alert, attentive, and fully oriented, appears has stated age and is appropriately and casually dressed, although slightly unkempt with wrinkled clothing. The mood is stated as depressed and affect is mood congruent with avoidant eye contact, less spontaneous movement and gesture, and occasional tearfulness. The thoughts are linear and logical, with themes reflecting low self-esteem, expresses guilt that does not rise to a delusional level, denies paranoia, religious or grandiosity, and bizarre delusions, and none are apparent, denies hallucinations, and does not appear to respond to internal stimuli. Denies current suicidal and homicidal ideation, intent, and plan, and demonstrates good judgment as evidenced by seeking treatment for depressed mood. Has good impulse control. Intellect is estimated to be average. No deficits are detected in immediate, short-term, and long-term memory, and usually they are able to interpret proverbs appropriately. The following lab tests may be carried out in the evaluation of patients with dysthymia. And these include full blood count, thyroid function test, folate or vitamin B12 levels, and homocysteine as well as methylmalonic acid levels. When it comes to imaging and functional studies, a functional magnetic resonance imaging or fMRI offers promise in the differential diagnosis of dysthymia if remains strictly a research tool. Single photon emission computed tomography or SPECT scanning is being offered commercially at some centers, but the existing database on depression may not be adequate, rendering this to be likely limited to an experimental study for the depressive spectrum. Electroencephalogram or EEG and polysomnogram data demonstrate that about 25% of people who have dysthymia have sleep changes similar to those of people who have major depression, including shortened rapid eye movement, latency, increased rapid eye movement density, and poor sleep continuity. Now let's take a look at the treatment. Psychotherapy and medication management are effective treatment modalities for dysthymia, and the combination treatment is common. Several types of psychotherapy are advocated, and this includes psychodynamic therapy, cognitive behavioral therapy, as well as interpersonal therapy. Short and long-term psychodynamic psychotherapy are effective for depressive disorders. In particular, they help in developing an individual's understanding of their relationships and decrease maladaptive interpersonal interactions. Antidepressants are effective in treating dysthymia. The mean response for any antidepressant in a review study was 55% among dysthymic patients. Doses are the same as those used for major depression, and success has also been reported with more noradrenergic agents such as mirtazapine, venlafaxine, duloxetine, and bupropion. So to summarize, we have understood that dysthymic disorder is a persistent depressive disorder. We have looked at the risk factors, causes, and pathophysiology, as well as the symptoms and the diagnostic criteria based on the DSM-5 criteria. We've looked at the assessment tools that can be used, as well as the techniques, which include excluding medical and substance abuse problems. We have looked at the roles of imaging studies, and finally, the treatment modalities, which is a combination of psychotherapy and pharmacotherapy. We have come to the end of this session. Thank you.